So we start this session. I'm Antonio Colombo from Milano, Italy. The first presenter is David Hildick-Smith from Sussex Cardiac Center in Great Britain, and Smith will present about complex and high-risk PCI. Should it be defined, and who should do it?
Thank you very much, Antonio. So, yes, complex high-risk PCI, so-called CHIP. Personally, I rather hate that acronym, but that's my problem. So what is complex and high-risk? Well, if it's complex, that means it's probably going to be technically demanding. Not always. You can't always predict that that's the case, but probably. If it's high-risk, self-evidently, adverse outcomes are more likely. But the definitions only overlap to a certain extent. So complex PCI is usually defined really by the anatomical factors, such as the angiographic appearance or imaging appearance, calcification, tortuosity, chronic occlusions, angulation, maybe bifurcations. Whereas higher risk PCI has a rather broader definition involving lots of things. We all know a high-risk patient just by looking at them. Age, mobility, frailty, degree of compliance, low body weight, all those kind of factors. Then there's the heart anatomical features. Of course, poor left ventricular function is a strong high-risk factor. Last remaining vessel, critical branches that can't be lost. Then the obvious comorbidities, renal function, lung function, etc. Concerns about vascular access, which definitely raise the stakes. So high risk may not be complex, and complex may not be high risk. And somewhere in the middle, they overlap. Here, for example, is a case that you could look at and say, well, this might turn out to be both complex and high risk. There's calcification, narrowing, poor caliber vessels into the LAD, important first diagonal, quite an angulation into a circumflex you don't want to lose. In the end, it's done with a relatively straightforward single stent, pot, kiss approach, and turned out to be neither complex nor high risk. Here's a case which definitely is high risk. Thrombotic subtotal occlusion of the left main, but it wasn't complex. Single stent to the left main is something that's definitely higher risk. A pretty remarkably unsuccessful bypass operation, which somehow ended in pretty much total occlusion of the left main, and it's only by the fourth image that you begin to feel you might possibly be gaining some element of control. And here's one which might be complex and it might be high risk. In fact, this is a case I did only a couple of weeks ago, a man with lymphoma who'd come in. His principal diagnosis was the cancer that he was under investigation for, but he also had terrible angina in the setting of a slightly low hemoglobin. In fact, it turned out to be neither complex nor high risk. It was a single stent strategy from left main into the only good vessel he had, which was the obtuse marginal, and a pot and kissing balloon inflation into the LAD, which was all he needed in the context of his ongoing investigations for lymphoma. He needed to be angina-free. So defining complexity can be difficult. Here's a paper from the UK taking all the data that's submitted annually into the BSIS database and looking at all these factors on the right-hand side from Mamas and his group, and identifying that actually the MACE rate, of course, goes up the more adverse factors you have. Who should be doing it, of course, is always a vexed question, because telling people what they can and can't do rarely goes down well, rarely fits with their perception, perhaps, of themselves. One thing we would probably all be able to agree on is that you need to be doing high volume if you're going to be doing difficult, complex cases. So here, again, from the BSIS, British databases, highest volume operators had the best results in terms of in-hospital and subsequent outcomes amongst patients who are having unprotected left main stem stenting. So I think we'd probably all agree, if you're going to be doing high risk or complex cases, whatever the exact definition is, you need to be high volume operator, maybe 200, 300 cases a year. You need to be experienced as well. You need to have seen a lot of stuff. So maybe 10 years of that volume is good. Interestingly, in the era of quite a lot of people doing a combination now of structural and PCI work, should the complex high-risk cases be done by operators who devote most of their time to PCI? Maybe, but I'm not sure, because the really difficult one is you want a good operator. And it's pretty hard, because everybody thinks they're a good operator. You're not going to tell someone, you're not actually very good at this, so I think somebody else should do it. You know, so that's very difficult. And what makes a good operator, I stole this slide from somebody, I quite liked it. You look at all these characteristics, you think, yes, those are good operator characteristics. You probably also think, yes, I have most of those, I'm a good operator. And probably everybody looks at that and thinks pretty much the same. One of the most important there is humility as well, I think, which is sometimes in short supply in interventional cardiologists. And finally, my favorite slide of all, which shows really that you can't, it's so hard to define something like this and make a sort of confined and compartmentalized assessment of, well, this is complex and this is high risk, because it's different for everybody. This slide, famous slide, the results from the Syntax trial, here's the cabbage mace and here's the stent mace. Don't go and have an operation done here by these people, whatever you do, and don't go and have your angioplasty done by these people. And what that means really is, of course, there are different aptitudes, different capabilities. And it's not just the individuals, it's the team, it's the center, it's the mentality within the center. So defining these things and rigidly applying them is extremely difficult. Thank you very much.
Thank you. We go to the next speaker is Gary Mintz from Cardiovascular Research Foundation. What is the definition of moderate to heavy calcification based on fluoroscopy or IVUS? Question mark.
Thank you, Antonio. It is a bit ironic that the oldest, most cited definition of angiographic or fluoroscopic calcium comes from a paper that I wrote in 1995 touting IVUS as the gold standard for calcium and criticizing angiography. But that said, this is typically what you see angiographically. Moderate calcium you see with motion, severe calcium you see without motion. These have been actually very, very useful in studying patient populations as a whole. And I'm going to go through several of them relatively quickly. This is a meta-analysis of 13 studies, 10 of which compared moderate to severe calcium versus no calcium, showing that calcium was associated with an increase in every single cardiovascular endpoint after DES implantation, all causing cardiac mortality, MI, MACE, TLR, and even stent thrombosis. And if we go to some of the individual studies, this is pooled analysis for Horizons, AMI, and Acuity, showing a higher event rate in patients with moderate to severe target lesion calcification compared to no or mild target lesion calcification. The same from a large multi-ethnic registry, and a study looking at no calcium, mild calcium, moderate calcium, and severe calcium angiographically from the ISAR group, showing that the event rates increase from no calcium through mild, moderate, and severe calcium. And then a study showing that second-generation DES seemed to be better in lesions with moderate to severe calcium compared to first-generation DES. But I like this study kind of a lot. This is from Asan Medical Center, the IRIS-DS registries, and although there was an increased event rate in moderate to severe calcium, in terms of impact on technique, it only applied to those lesions with severe calcium, that better technique resulted in better outcomes. These definitions have then been used in a number of randomized trials trying to define a better PCI approach for calcium. And again, using the same angiographic fluoroscopic definition that was first published 30 years ago. Going to intravascular imaging, because that is the alternative, the advantage of intravascular imaging is in individual patients, not so much in populations. These are 12 IVUS studies and 3 OCT studies showing that the angiographic appearance, the imaging appearance of calcium is remarkably similar regardless of the machine, going back way to the early 1990s and even most recently with high definition IVUS. Back to my paper in 1995, it isn't until you get to 4 quadrants of calcium that the angiogram becomes even reasonably accurate in terms of detecting moderate to severe calcium. And if you look at angiographic calcium, non-moderate, moderate, and severe, you can see that target lesion calcium by IVUS increases, the arc increases, superficial calcium increases, the arc of superficial calcium and so on increases. And when you're dealing with severe calcium, you're dealing with an arc of lesion calcium of about 240, an arc of superficial calcium of 215, and significant lengths of calcium. And of course, IVUS looks at the arc and the length. OCT can look at the arc, length, thickness, area, and volume. And so when we look at IVUS, OCT, and angiography, while the detection of calcium is the same by OCT as it is by IVUS, the ability to look at thickness, area, and volume is a clear benefit for OCT. We have now published 2 calcium scores, one using OCT, combining the maximum arc of calcium above 180, maximum calcium thickness more than 0.5, maximum length more than 5 millimeters, and if you have all 4 points, you can predict stent expansion, under expansion, and by IVUS we use only looking at lesions with at least with more than 3 quadrants of calcium, a length of calcium more than 5 millimeters, the presence of a calcified nodule, smaller vessel size, and completely circumferential calcium, any 2 points predicts stent under expansion. There have been a number of algorithms published, this one from the UK. Adrian Banning, is he in the audience, was the senior author. And this is something that we published in the British journal Heart, again based upon intravascular imaging assessment of calcium in individual lesions, deciding whether or not it is necessary to then proceed with calcium modification prior to stenting. What we have learned predictably is that you have to cause calcium fracture before you place a stent. So you do calcium modification if you're worried, you repeat imaging, you look for calcium fracture. If you've got fracture, then you can place the stent and get good expansion. If you don't have fracture, you've got more work to do before you place the stent, because the worst thing to do is to place a stent that you can no longer expand. By IVUS, this is one thing that I wanted to point out. You don't always see the break in the calcium by IVUS, but you see distal vessel wall that is otherwise not seen. Remember, because of shadowing, you never see the deeper vessel structure. If the deeper vessel structure appears, then you know that you've caused calcium fracture. So to quickly answer the question, is the definition of moderate to heavy calcification based on fluoroscopy or intravascular imaging? The answer is both. It depends on the situation. Angiography is great for looking at populations, unless you have enough of a database that you have IVUS in all the patients. But when it comes to an individual patient and how to best treat that patient and how to get stent optimization, angiography fails and intravascular imaging is the technique of choice. Thank you for your attention.
Thank you. Thank you very much. The question will be at the end. We have a session dedicated to discussion. George Dangas from Mount Sinai, New York, will give us the essential about calcium management. Okay, so this is the one.
Okay, great. Thank you. And I'll be able to run a little bit faster in my initial slides because Gary gave such a great talk on the IVUS diagnosis, I would say. And indeed, there is a very old classifications of the calcifications of the vessels. And you can see the original CCHA, as well as the fact of the matter of why we're dealing with calcium. That's the most staggering, I would say, example, because we may end up left to deal with a problem of having a stent that is terribly underexpanded because, in retrospect, we regret we underestimated the calcium and treating of calcium in time, obviously for the reason why we underestimated the severity of calcium in that specific vessel, in that specific lesion. That's exactly what Dr. Mintz showed us about the individual patient assessment. These are the definitions of severe calcium. You can see the Trump track and all that Dr. Mintz explained those very well, as well as the point system regarding how to get the calcium assessment per patient, and as well as this aspect. So in the rationale of the calcium and the OCT, trying to the calcium and the by IVUS OCT and assessment in combination with angiography can be very confusing because trying to figure out a step-by-step assessment, that's all it is. It can be a little complex when you try to put all in a slide. Some lesions are small, some lesions are complex. You may need to pre-treat and modify the plaque, and ultimately you need also a post-assessment and ultimately check your apposition and expansion, and obviously adequately support the hemodynamics of the patient in case it's a truly cheap case and you need a lot of time and peace of mind in order to do all the assessment that you need. So let's go through the various possibilities that we have in order to treat calcium, and you can see the management of healthy calcified lesions includes all possible these devices, these types of devices. Some of them are reserved specifically for extremely severe calcium you see at the bottom. The specialty balloons can be very useful when the lesions are perhaps short or perhaps confined at the ostium of a branch. That might be a good option for these types of lesions. Fibrotic ostial side branch particularly, I would say, or dealing with a moderate calcium. Rotational atherectomy and nobular atherectomy, we move on into different techniques, different ways to treat the calcium. However, they both ablate in some way or another, and clearly severe calcium is requiring one of those, one can say. The rotational atherectomy specifically, you need to really know the technique as well as know the preparatory elements of to prepare as well as to avoid the complications, and particularly the reducing of the speed and the calming down, that even the lower speed is a way to start, not at the very high, due to the higher platelet activation in the high speed, as well as not much difference in ablating ultimately the calcium. The slow flow and the perforation is ultimately what you really need to be concerned about, and you need to be able to accept some level of CKMB release after the procedure, because a lot of atheremboli are going to go different places, no question about that. Starting small initial burr is a lesson that one needs to always know. The short ablation runs and the avoidance of the RPM drops, that is a very important aspect, as well as adequate platelet inhibition cannot be understated in this technique. You need to really be very, very careful avoiding all these three things at the bottom: the burr stalling, the guidewire fracture, and the burr detachment. I think those are best presented in complication sessions. Otherwise, they cannot be really taught in a didactic scenario like this talk. The orbital atherectomy is a newer device. I'm not sure available here or definitely available in the United States, not as common in other places in the world. Has definitely an easier setup, at the same time maybe have a little bit of a more difficulty as far as safety in the angulated lesions. The The ongoing ECLIPSE trial deals with those aspects, the evaluation and treatment strategies for severe calcific lesions, orbital atherectomy versus conventional angioplasty prior to implantation of the drug-eluting stent is ongoing study and hopefully will complete soon. Dealing with a laser, which obviously perhaps even older than Gary's paper that he showed us before, there's a way, although laser is particularly good with the thrombotic lesions, one could say, and that's how it started. It actually, if you combine with a contrast injection at the right time, the smallest laser can create some kind of a controlled or not so controlled bomb effect, localized mini explosion, so to speak, and ablate the calcium. It can be particularly handy if you have a calcific nodule that prevents you from advancing equipment and going forward, whereas you can do other techniques once you get rid of that initial bump that doesn't allow anything to be advanced. Well, it's particularly helpful for uncrossable lesions. Actually, there's a new laser coming up covered with a sheath in order to allow now a little bit more control of this micro-explosion, one can say, so you can inject through the dedicated sheath of the laser, that's around the laser, some dye and activate. So therefore, the bubbles, one can say, can be contained inside that sheath. To be continued about that. And there's some studies about this technique that's a little difficult to study because not only is it off-label for FDA, but also potentially dangerous to study. Ultimately, we have a new device that came about. It's a balloon, and it's very handy in that many people are, one can say, not so facile in utilization of the atherectomy devices, may be concerned or even a little bit, quite a bit scared about them if they don't use them often. Lithotripsy is a balloon, so maybe a little bulkier than the usual balloon, but it is a balloon nonetheless and can be inflated, but maybe few atmospheres, and then it's activated and radiates some pulses around that fracture the calcium. And you can do up to 8 inflations of 10 seconds each, and ultimately you get some good expansion, and it comes in different sizes of balloons. It's particularly helpful that it can even be used in combination with an atherectomy technique if you're treating a very large vessel. So you're starting with a small vessel burr, and then sure, you use a 1.5 burr, and the vessel is 4.0, 4.5. Then what are you supposed to do? You cannot really ablate to that level, and perhaps you not be able to expand a stent up to 4.45 if you only dilate past an initial burr or an orbital. So following that, you may want to perhaps this technique up to even 3.5 or 4.0 vessel if need be. It's also available in the periphery, so that the size limit is not there. So it can be particularly helpful for these larger vessels, one can say. There are different studies, but clearly small kind of feasibility assessment, and obviously due to being a balloon and highly, I would say, familiar of how to use a balloon, has some certain safety features that are, undoubtedly obvious to everyone. In dealing now with a summary of where are we, and particularly offering our own center's experience in this, the calcific lesions, you're dealing with moderate, severe calcification. You can deal with the ability to cross an imaging device and further assess. You can see that on the left screen. That's the green screen. And according to the point system, if it's low number of points, you can go with a specialty balloon, a high-pressure balloons, and otherwise you can ablate perhaps with a lithotripsy balloon or a limited atherectomy device. And ultimately, if you continue to have suboptimal result, definitely use a lithotripsy and the stent. Further on, if you cannot even pass an imaging device, and that's on the right side of the screen, then you're dealing with an uncrossable lesion or perhaps other difficult situations. And therefore, you can employ one of the atherectomy devices that I showed, either the laser that I said is specifically if you feel that there is only mainly one spot that gives you the main problem, or the other techniques, and again follow up as I indicated, even with lithotripsy, if not with the optimal expansion of the stent after that. So with use of rotablator, IVUS, or OCT, upsize the burr as needed, ultimately do a balloon expand or a stent, or if you want to just go to a rotablator plus IVL and stent, maybe you bypass a few of the other aspects if you're really certain of the sizes you really want to use later on. So in complex cases, and at the end of the thing, ultimately you're really going to have the stent optimization and absence of dissection with deposition. So the final imaging is very, very important in this lesion subset. This is another way to look at the various things with, of course, include patients, and clearly if there's many of those lesions in one patient, you may also consider surgery as a possibility if you really need to do this kind of thing in all three vessels. And otherwise, I think this latter part of the slide is exactly the same as Joanna showed you before. If you need some online assessment, if you don't have any of the experts on this panel or in this room around you, you can actually go to your iPhone and you can download the app that deals step by step with those aspects. It's a free app, Calcified, and that could be very helpful to you about what steps to use and how to proceed from where you are. So in conclusion, you really need to deal with calcification very seriously. Otherwise, you're going to be left with a particularly uncomfortable problem of a stent that is suboptimal and you don't have a clear way of what to do next. That's the one line, and I'd like to thank you for your attention and congratulate the organizers of TCT Asia Pacific once again for coming really strong in a live meeting 2023. Thank you.
Thank you. Thank you, George. And so I'm going to move to the next speaker and the practical approach to calcified region. When do we have to consider ablation? Is it Do-Yoon?
Thank you for introduction. I'm Do-Yoon from Asan Medical Center. Because two masters of the calcium already mentioned everything about the calcium management, I will just share our case and I will show the Asan Medical Center style. Because in Korea, now the lithotripsy and orbital atherectomy is not available. So the only available atherectomy device is rotational atherectomy. And many Asian countries have the same situation. So please think about that. This is our registry data that already Gary Minch showed that clinical outcome by calcium, severe calcium is worse. Why? One would be that calcium is the marker of the extent of coronary atherosclerosis. That means the underlying worse patient condition. Other would be the calcification result in suboptimal stent result because of the impaired stent delivery, decreased stent expansion, malposition, stent asymmetry, and also complications like dissection or perforation. And during the calcification region PCI, we should always prepare for the worst situation. Warning for the patient and strong guiding catheter bagger, including guide extension catheter and preparation of the atherectomy devices. And the PCI for heavily calcified lesion, always the important thing is the lesion preparation. And as two speakers already emphasized that do not stand on poorly prepared calcification. It makes disaster. This is an example, 65-year-old male patient, stable angina, and 2.5 millimeter balloon and 3.0 cutting balloon, but you can see that the balloon is not fully dilated. Even IVUS, there is no calcium break. Stent should not be implanted, but stent was placed, and then it does not expand at all. It does not expand. In angio, it looks okay, but in IVUS, you can see the stent mal-expansion and does not expand with the 3.5 or 3.75, even at the very high pressure. Finally, with the 4.0 at 34 atm, it's a very dangerous situation, and it is opened, and IVUS, you can see the opening of the calcification and stent. And please avoid this dangerous situation. Confirm the calcium breakage in IVUS or OCT, and even also in angiography, you should check the Hsieh. And if this kind of sign, you should not place the stent and check the calcium breakage. And we have many weapons as shown in the previous slides, and I will talk about the rotational atherectomy. When do we consider rotational atherectomy? First, balloon or IVUS catheter does not pass. Second, undilatable lesion with the NC balloons or cutting balloons. 75-year-old women with effort angina, RCA shows severe calcification and catheter does not pass. And the 1.0 or 2.0 balloon pass but does not expand. And did the rota or the 2.25, 1.25, and 1.5 millimeter bar with the pre-medication. And usually I use the pacemaker. And it success to cross the lesion. Because of tortuosity, you need to push slowly. And check the calcium fracture. After that, did the NC, and we could obtain the good result with the stent. And third, with the high degree of the calcium, especially for the calcium nodule. The 66-year-old man with the effort angina with the instantary stenosis. And RCA, there was severe calcification showing the very heavy calcium, maybe calcium nodule. Wiring success with the Geisler and Hsieh, and wiring very difficult. And change the wire to stiff wire and try to balloon but no response. Check the IVUS. IVUS show the diffuse multiple heavy calcium nodules. And we did the rotablation using 1.5 millimeter bar for reduction of the calcium volume and debulking and to open the lumen. Slowly did the rota and success to cross the lesion. Did the multiple runs to debulk the lesion, and for rotabulation still there is severe calcification. But after NC and stenting was done, and very high pressure balloon of the 4.0 balloon was done, you can see still there is severe calcification here. Maybe the lithotripsy can help. Dr. Ali will show. And another would be the debulking for instantary stenosis. The 68-year-old male gentleman, bare metal stent implantation 12 years ago. And pre-balloon. And in stent, it does not expand. You should check the Hsieh image and see carefully whether the balloon is well expanded or not. Did the 3.0 NC up to high pressure, but do not respond. And IVUS shows severe calcified neoatherosclerosis. And did the rotabulation with a larger ball, 1.5 and 1.75 for debulking of the instant calcification. And post-rota IVUS shows the disruption of the arc of calcification. Then you can see the balloon is expanded. And the lumen is restored and finish the procedure with the drug-eluting balloon at previous stent. And the imaging for calcified lesion PCI, so with the IVUS or OCT, you can see the calcium arch and thickness and length. And as shown, the calcium scoring system is very useful to predict the stent expansion and to make the decision to use or not the rotational atherectomy. And the most important thing is to check the calcium breakage at imaging and vessel size by imaging. Too large size make this a disastrous perforation. Perfection is the enemy of good in severely calcified disease. And also, the underexpansion or malproportion can happen, but I think that good would be better in this situation. And after PCI, post-IVUS surveillance is crucial and to make the correction if there is underexpansion or edge-related problems. And this is my practical approach in Asa Medical Center. And severely calcified lesion on angio and intracorneal imaging we use. And if the catheter does not cross and the rotational atherectomy is done. If it crosses and imaging-guided pre-lesion modification, still there is no calcium break, consider rotational atherectomy. After every effort to make pre-lesion modification and then imaging-guided stenting and stent optimization and imaging surveillance would make a good result. And always prepare for the worst situation. In summary, always we should prepare for the worst situation in calcified lesion PCI. Intracorneal imaging is very helpful to plan the strategy, guide the procedure, and finalize the result. And prepare the lesion before stenting, and please take care of post-stent optimization also. And safety is the first. Do not oversize too much. Thank you for your attention.
Okay, thank you. We're gonna move to the Professor Jihad Ali and the intravascular lithotripsy for severe calcified lesion. And Jihad?
Okay, thank you very much. So since this is in the tips and tricks session, what I'm going to do is talk to you about tips and tricks about intravascular lithotripsy. My major disclosure was that I was a developer of this technology, so I owned equity in Shockwave. So the first thing to understand is the field effect of how IVL actually works. The impedance of calcium is very, very high. The impedance of soft tissue is very low. So the impedance in your pulp of your finger, for example, is about 1.5 times that of water. And that's why you can hold the lithotripsy balloon and it causes no damage. On the contrary, when you're opposed directly to something hard, the impedance is hard, it will break it. Why is that important? It's important because the same things exist in your coronary artery. When you have superficial calcium that's abutting the lumen, that's very hard, analogous to you hitting a hammer onto a windshield. If you hit a hammer on a windshield, it will break. The neointima is like a sponge. If you hit a hammer onto neointima, nothing will happen. And this has very major implications for the size of your balloon. So what happens when you use an IVL balloon that's too small? There's significant soft tissue impedance between the balloon and the calcium. Therefore, most of the shock wave will be absorbed. So in order to minimize the impedance and maximize the energy that goes into the wall, you need a bigger balloon. The bigger balloon squeezes the pillow, reduces the impedance, and allows more energy to go directly into the calcium. So avoid the concept of using a small balloon for safety for IVL because you're only inflating at 4 atmospheres. The placement of the emitter is critically important. As you know, these are the different technologies. In the coronary, you have 2 emitters which are actually diametrically opposing. You don't know which way the emitter is facing. So while IVL gives a circumferential pulse wave, the emitter actually lets the energy out of north or south or east or west, which you will not know. And therefore, the placement of your emitter across the calcified segment is critically important. Remember that the emitters are actually not centered. From the distal marker, there's a 4 millimeter gap to the first emitter, then 6 millimeters to the second emitter, and then 2 more millimeters to the distal radiopaque marker. The reason they are offset is to allow delivery of the proximal part of the balloon into the lesion and improve crossing profile. Now, you'll see what I'm doing here is actually moving the emitter so that either one of the emitter is facing this segment of calcium. This is important because you don't know which side the energy is coming out of. To maximize your likelihood of fracture, you need to move the emitter. Now look what happens to the calcium when you get the emitter right across from it. Even on advanced fluoroscopy, you can see fracture of the calcium. Tip number 3 is pulse management. You have 80 pulses, you need to use them wisely. If you have a heavily calcified segment, the emitter should be moved throughout. And what you'll see here is on this video is us moving the pulses just a couple of millimeters at a time across the calcified lesion. If you have a short lesion, you should spread the pulses through the short lesion. If you have a long lesion, you should use about half of your pulses in the maximum calcified segment and the remainder of your pulses anywhere that you're going to lay a stent. Tip number 4 is to use your advanced fluoroscopy. This is how we conventionally look at calcium. Calcium that's on both sides of the arteries is considered to be severe. This is the state of the art for calcium detection. Most of you have it in your lab, most of you never turn it on. This is device detection by Philips. You can see very clearly where there's overlap of the calcium. You can see the emitters with crystal clear penetration, and you want to place your emitters immediately across from the calcium. This is an example of advanced angiographic co-registration where you can place the emitters on each side across the vessel wall to make sure that you can induce fracture. And here's an example. On the left side, you see baseline. On the right side, after 20 pulses, across from the emitters, and you'll notice that you can detect calcium fracture even on X-ray by advanced fluoroscopy. Air absorbs shock waves, just like an airbag absorbs energy. If you have air in your balloon, it will reduce the efficacy of your shock amplitude by 20% and reduce your fracture by 40%. Remember, air is inevitable with IVL. The mechanism of action is to create vapor bubbles. If you don't see air, something's not right. Expect to see air every 20 to 30 pulses and use 50-50 contrast. Look at an example of when there's air in the balloon and immediately after removing the air, there's a significant improvement in expansion because the air is being removed. Tip number 6 is important. There's a strong difference between inflation and dilation. IVL is an inflation at 4 atmospheres. It is not dilating the lesion. And that's important in terms of safety and why you can use a bigger balloon. You can use a bigger balloon because you cannot perforate an artery at 4 atmospheres of pressure. The balloon will slip. So using a larger balloon at low atmospheres will squeeze the intima and provide the maximum penetration into the calcium. Also understand the mechanism of IVL is to create cracks. The mechanism of your NC balloon is to use brakes. So IVL cracks and NC breaks. So follow your IVL with an NC balloon to move these plates. Understand that cracking versus breaking, often you'll have this type of result after your IVL. A rather substandard, poor appearance where you think this didn't really do much. But look what happens when you go with a 20 atmosphere balloon immediately following that. When you go at high pressure, you'll actually fracture the calcium, move those plates away from each other, and lead to a significant yield. Use a guide extension. This is a very, very important concept because probably the biggest barrier to IVL use is delivery of the balloon. You can improve your delivery access to the lesion to about 95% by using small balloons and a guide extension catheter. And here's how you do it. It's very simple. Here's an example of a balloon not being able to cross a calcified lesion. You simply use a semi-compliant balloon and use balloon-assisted tracking of your guide extension catheter. And once you've got your guide extension catheter in place, it's simply unsheathing of this IVL balloon allows you to optimize your placement of your balloon and then to see immediate fracturing and lesion yielding. Pulse division is an important concept. By pulse division, what we mean is you want to move, if you have only 80 pulses, you want to use them very wisely. So you can use 40 pulses on one side and 40 pulses on the other. Here's an example of IVL being used with a guide extension in the circumflex. And very soon after using your balloon, you can take your guide extension, keep 40 of your pulses, deliver it into the other branch, deliver your pulses, and optimize the use and cost of your device by using the guide extension catheter. Here's your final angiogram. Finally, understand wire bias. Understanding wire bias is you'll see, if you see the wire abutting the calcification, your lesion is not prepared. What should happen is your wire should be in the middle after lesion preparation, and this will happen progressively using IVL. Here's an example. This is the pre-balloon. This is a 2.5 semi-compliant balloon. You can see the wire is completely eccentric. But as soon as we start performing IVL, the lesion yields and actually leads to centralization of the wire. So these are my top 10 tricks for optimizing IVL utility. Thank you very much.
Okay, thank you, Jihad. And so after two case discussion and then two case presentation, we will have discussion time. So I'm gonna introduce Dr. Antonio Colombo and the heavily calcified region.
So this is a LED with diffuse disease. You see the tight lesion after the diagonal, big diagonal. In this case, OCT crossed the lesion, so following what we just heard, we don't do rotational atherectomy. It's not wrong to do rotational atherectomy, but let's say this is not a must. The calcium is very severe. Here is the steel frame. So in this case, because of the extension of the calcium, we elected to use a Shockwave at the beginning. Again, there are many ways you can deal with this. You can use high-pressure balloon first, nothing wrong. The high-pressure balloon may expand, and then you save a lot of money. You may do Shockwave. The Shockwave will not cross. Then you predilate with a trio balloon or use an extension catheter. So it's really, the algorithm is not one way, there are different ways. In this case, we use the Shockwave 3.5 balloon. The balloon seems to expand, but sometimes does not expand, and as you saw in the presentation before, does not mean that the calcium is not broken. This after 8 sessions with the Shockwave definitely looks better. But after the Shockwave, we almost always do high-pressure balloon. I think it's a must because you need. You see there are some cracks, but not so evident. Not so evident. In the picture, the ad showed it's really clear that the dish, the plate is not broken. You may need some additional help. It doesn't mean that the Shockwave has not worked. It means that the lesion was prepared, but not completely, and that's the reason why you need high-pressure inflation. We go up to 24 atmospheres, and again, I'm not so sure that if you did this before the Shockwave, you would have had the same result. And this after high-pressure expansion, the result is pretty good. Maybe you don't even need a stent. So then we implanted the stent, and again, after there is some air there, and after the stent we do post-dilatation, and we do, in this case, OCT. But you see there is a nice morphology. It's really, and this round morphology is not easy to obtain unless you have multiple fracture of the calcium. If you have only fracture in one side, it's difficult to get this round morphology. So after the Shockwave, and then high pressure, and then stent, and then very high pressure. So here is this quick. This is another example. It's a strange example. This is an occluded stent. We went subintimal. We were not able to go in the stent. We crushed the stent, and was heavily calcified. And we did a Shockwave inside the crushed stent, and then that really shows the need of multiple devices. Angiographically looks reasonably acceptable, but look at the morphology. Terrible morphology, very asymmetric, and in this case we used OPN, high pressure balloon, to 37 atmospheres. So we did not get an optimal result, but if you compare with the prior morphology, the difference is quite evident. So these I just showed this slide to show that sometimes you need multiple devices. One device is not enough. Sometimes after shockwave, you need cutting balloon at high pressure, and after the high pressure cutting balloon, you need OPN. So it's really a series of multiple devices. But to me, one important statement is rotational atherectomy is very important and underutilized in calcified lesions. So we have to be to follow what George showed, the Mount Sinai approach, that rotational atherectomy should be used more frequently. Doesn't mean that it's the only device, but it's an important device to be used more frequently. Thank you for your attention.
So we're going to move to the last lecture and the case presentation, Dr. Chan from diffuse long region.
Well, thank you very much for the invitation. I need to go a bit fast, nothing to disclose. I want to start off with the case that I did a few months ago. 66 years old gentleman, multiple risk factor, renal failure on dialysis. Well, he presented with chronic stable IHD with increasing symptoms despite adequate medical treatment. We did a Fahim scan, which is positive, with reversible ischemia in the LAD. Echo, well, LAD region hyperkinetic, EF 45%. So we performed a coronary angiogram, which mainly show LAD very long diffuse calcified lesion with a left shirt moderate lesion. The RCA only minor disease. So we discussed with the patient, and then he preferred PCI. Well, you can appreciate that the LAD very long diffuse, actually almost to the extent of subtotal occlusion with culprit lesion is the LAD. So what are the management strategies? We need to consider several factors. The patient is a relatively stable case with symptoms, present with very long diffuse calcified lesion in the LAD. Well, this lesion is prone to high MACEs with high TBR rate. So I need to ask myself, what's the best treatment strategy? Medical, PCI, or even cabbage? Well, the patient prefers PCI, so what are the approaches? Are we going to use IVET guidance, anatomical approach, spot standing versus long multiple standing, or use of drug-coated balloon, or perform some calcification modifications as our previous speaker alluded to? Or how about the changing concept of using physiological guidance to guide our revascularization strategies? Well, we use a wide radial approach, and we use a turnpike LP catheter supported by run-through, and then the lesion will cross by XTA. We use multiple small-size balloon, and the IVES catheter all fail to cross. We perform granuloplasty in just put a balloon very close to the lesion, but all fail. So you use anchor balloon technique, guide extension. Again, we fail to pass anything. Well, no choice. We need to change to a rotor floppy guide wire, perform rotor ablations, and then stepwise balloon dilatation. And we perform IVES, which demonstrate very severe long diffuse calcified lesions. And then we perform 2 overlapping long stent, high pressure balloon dilatation, again, optimized by IVES result. I don't have time to show the IVES. Well, the distal LAD still reveal very long diffuse disease, so we treat it with a complementary drug-coated balloon, all right? Well, the result is quite satisfactory, I must admit that. But I need to ask myself, will the long-term standing result satisfactory also for the patients? Well, just some discussions. Why the long diffuse lesion is complex? Well, actually, it consists of about approximately 20% of current-day PCI associated with multivessel disease. Incidence tend to increase because of increasing DM and increasing surgical turn down by the surgeon in the very elderly. This definitely is a high-risk lesion subset. We create therapeutic challenge, and most of these lesions extend to small distal vessel involvement in bifurcation, and we need to treat these long segments by multiple long stent implantation, and then tend to associate with poor long-term clinical outcome, stent thrombosis and restenosis. Again, high incidence of periprocedural complication, and not to mention the cause. Well, studies have shown that the stent length is the most important independent predictors of subacute stent thrombosis and stent failure rate. All right, the problem long overlapping stenting, and actually the long death force trial have actually revealed a 14% TLR rate at 1 year due to more implantation, multiple stent, and longer stent length. In the contrary, there's some new generation, very long stent, have demonstrated by the registry data that in long diffuse lesions, the 1 year MACE rate was quite satisfactory, all right, up to 4%. Again, there's increasing evidence that the role of drug-coated balloon in these long diffuse lesions. For example, the trial have shown that the efficacy and safety of drug-coated balloon strategy in combination with drug-eluted stent are very similar to those of drug-eluted stent alone in these long diffuse coronary lesions. While all the previous section that mentioned about the role of functional guidance, right, is a class 1 indication for those moderate disease. So I want to present a case of illustrated changing concept. Can we change our anatomical guided mindset to physiological guidance of revascularization, especially for these long diffuse lesions? Do we have any latest evidence on that? What are the rationale of using physiology guidance in these long diffuse disease? The clinical significance of moderate diffuse long lesion can be uncertain. Many of these lesions may not associate with visually severe stenosis, so physiological assessment with a pressure wire pullback, which can precisely identify the site of hemodynamic significant pressure drop. In this diffuse disease, the pressure gradient may be gradual or mild in some segments, while other regions may have a very sharp significant pressure changes across specific area, which contain the most functional significant lesions. So by this pressure wire pullback, very useful for PCI planning in these long diffuse disease. We can place the stent strategically in a parsimonious manner so to intervene only the functional significant area that will maximize the PCI blood flow. Well, a Japanese colleague have illustrated study by characterization of the disease pattern by this physiological guidance by using a motorized FFR pullback, where we can easily distinguish the disease pattern into a focal diseases versus a diffuse diseases. And it creates this sort of pressure pullback gradient is a novel approach to quantify CAD as focal or diffuse. And the pullback pressure gradient is a continuous metric where you're approaching 0, representing diffuse disease, close to 1, characterizing focal disease. And they also illustrated differences in PCI outcome. For those focal disease with a high pullback gradient, which confer a better outcome, higher PCI FFR, and larger MSA, which are all markers of improved PCI durability. On the contrary, for those diffuse diseases, low pullback gradient, which study have shown that it conveyed a poor outcome with low PCI FFR and smaller MSA. And also, the pullback pressure gradient being assessed as a continual variable is strongly associated with change in the FFR after PCI, which is a parameter predictive of angina relief after PCI. Then how about the role of other non-hyperemic pressure indexes? Because FFR rely on maximum hyperemia, so if we want to assess individual area within this long diffuse disease, or to isolate relative significance of the focal severe lesion, then FFR may be suboptimal because it's challenging to deconstruct the relative contribution of individual lesion in the state of maximum hyperemia. So these non-hyperemic pressure indexes measure the physiology in the resting state. They are a suitable option for pullback study to create an accurate physiological map along the entire lesions. Nowadays, with co-registration technology, we can provide overlay of physiological map directly onto the coronary angiogram for the precise localization of significant lesions. So one example is IFR pullback in long diffuse disease, which allow a point-to-point measurement alongside the entire coronary vessel without the time restriction linked to the hyperemia, so we can separately interrogate different parts of a long diffuse disease vessel. With the motorized IFR pullback recording, combined with the real-time computer tracking of the pressure wire movement, actually can provide a complete physiological map of the coronary vessel. With this co-registration technology, we can provide a fusion of the physiological and anatomical information. Well, this is the Amirali trial, which is actually the first randomized control trial to assess the potential utility of this co-registration guided IFR pullback to guide our revascularization long sequential diffuse coronary artery disease. We are pending for the result. Well, with the IFR co-registration pullback, we have an entire physiological and anatomical angiogram roadmap. And then by doing that, we can do that before the angioplasty. And we can perform a virtual intervention. And then we predict the hemodynamic outcome, which is the PCI FFR for this severe lesion and long diffuse arterial lesion, to predict the site of accurate standing. So by having this sort of virtual IFR pullback, we can predict that very strategically the length of the stand, the exact site of the stand. And this it's very useful for us to calculate the effect of removing a stenosis, and this is the most important predictor to protect the residual ischemia after the intervention. Another non-hyperemic index, for example, the QFR, the quantitative rho ratio, we use the corneal angiogram to guide us for the serial corneal lesion. Again, it's a very important latest technology to allow us to perform this sort of virtual PCI to predict the site of the stenting in this very long diffuse lesion. For example, by doing this QFR technology, we can predict exactly the post-PCI result. Time limited, I do not want to go to the CT FFR. There are a lot of data on the role of this using a CT FFR to predict the post-PCI result in long diffuse lesions. Well, this is another cases that I recently did a couple of weeks ago. Again, very long diffuse moderate LAD lesion, and this we perform an FFR pullback of the LAD and the left side. Of the midpoint is a FFR motorized pullback. We use adenosine infusion. You can see that the LAD lesion is 0.92 FFR. So for this patient, we just leave it alone. We assure the patient, put the patient on long-term medical therapy. So ladies and gentlemen, in conclusions, long diffuse lesions still pose a great therapeutic challenge in current-day PCI. Current PCI strategies for these with long-standing in the long diffuse disease still carry very high TFR and MACES rate. Long stenting with complementary DCB under intravascular imaging guidance is technically feasible and tend to have good immediate outcome. However, there are more emerging evidence suggests that a changing in concept to physiology-guided revascularization approach in this long diffuse lesion may have a better outcome. And the use of a non-hyperemic pressure ratio is a promising tool to guide the strategy in these long diffuse lesions. However, definitely we need more clinical trial and data to decide on the best treatment approaches for these long diffuse lesions, either medical treatment or PCI or CABG, especially if they're stable. Well, this last slide, just to remind every one of us that the revived PCIS2 clinical trial showed that there's no survival benefit for those PCI group versus the optimal medical therapy group, even in these patients with ischemic cardiomyopathy, with EF less than 35%, with viable myocardium demonstrated by this stress test. But the most important differences is still the quality of life, is a symptom in the PCI group. So we need to have a better strategy to predict the post-PCI symptom relief, especially for these long diffuse coronary lesions, before our justification to perform the intervention. With this, thank you very much for your attention.
Okay, we will have some discussion time, and any question or any
Yes,
comment?
yes.
I didn't understand the last slide. You're talking all the time about physiology, and then you came up with a slide where there was no physiology ever used.
Yes, I fully agree. Well, because the revived BCIS clinical trial actually create quite a lot of controversy, even in my own department, all right? Because, we are doing, apart from the ACS patient, we still have a large burden of patients that coming in because of this chronic stable ischemic heart disease present with symptom. And then we're also doing quite a number of CTO. We got a CTO expert. So actually, we are being challenged by some of, even within our group, that would be PCI, with the PCIS2 revived clinical trial. Are we still doing that? All right. So that's why, I agree with you that, this trial is definitely not related to physiology, all right? They do not use any IFR, CT-FFR, etc. in the PCI group or in the PCI versus the OMT group. But I think, it gives us I still cannot understand why, this sort of high-risk patient with ischemic cardiomyopathy, heart failure, they have demonstrable viability, and the fourth segment of viability, they have the BCIS, Jafary score. Well, this is definitely high risk. I don't understand why, a PCI to the lesion can't help. No, but definitely, that's why, we still do this regularly day in, day out, but now, because with the trial result, I need to explain to the patient that it's mainly for symptom. all right? I can help you by doing PCI. Well, even though you're chronic stable, but you have viral myocardium, I can help your symptom. Of course, the first most important management is still guideline-directed medical therapy. But what I'm trying to bring out is that many of the time,
Okay,
even
could you-
after
could you-
PCI, we
could
still
you-
have a lot
okay.
of residual.
Yeah, we need other people.
Yeah, sorry for that.
Okay.
Can I ask
I
questions?
have a question for Dr. Ziad.
Yes, yes, I have
Um,
questions. Yeah,
Regarding lithotripsy, is that there are some situations where you would lithotripsy at the very beginning. Why not always try with a high pressure balloon before?
That's a great question. So at least theoretically, a NC balloon should create a fracture in a single plane. So it will create one fracture. You very rarely get multiple fractures, and it's usually in one axis. IVL creates fractures in a completely haphazard form. So the analogy would be if you crack a patio plate, it will crack in one dimension. But if you use lithotripsy, it'll break into small pieces. So theoretically, you should improve the compliance by having many, many more fractures, which we've seen on CT.
Yeah, I tend to agree with what you said. I think in our early experience with high pressure balloon, we got a nice lumen, but there was a lot of asymmetry. And the asymmetry is related to single fracture. If you have multiple fracture, you have more circular pattern.
We just, hopefully this will be published very soon. We just have in final review the eccentric paper in circulation intervention and answer exactly your question by OCT. When you have those eccentric lesions, how do you get the circular stent? And that's because even when you have eccentric calcium and you create a fracture, it pulls the plates away and creates a circle with the stent.
Yeah.
But following this question, what if there is a severe dissection even with impaired flow after the high pressure ballooning? Because at that time, what can do next? Maybe atherectomy, which kind is better, or may worsen the situation? Or by that time, we'll say, okay, in the beginning, we should do the atherectomy first.
Maybe normally once you have a really good dissection, it's actually a good sign that your plaque is already modified. But if you end up seeing that the plaque isn't modified on imaging, I think it's reasonable to do atherectomy, not orbital atherectomy, but I think atherectomy is still reasonable if you don't lose wire position, right? For sure, you have a certain higher risk for perforation, but better to put it as in compared to just to put a stent, right? That should be avoided, right?
I want to ask Ziad, so it's not common that we get to speak to an inventor of a technology. So Ziad, can I just ask you one technical question and two feedback? One of which is, do you actually increase your inflation pressure to 4 to 6 hemispheres towards the end of a run of, I don't know how many pulses? And two feedback here. Number one is, could you possibly increase the pulses to beyond 80 and not stop it? And the second feedback is, can you do something about the 4O profile? Because even that 4O profile has difficulty going through a guide extension catheter if you want to use it. So
you have to remind me, your first question was about?
4 to 6 hemispheres.
So no, because you get 50 atmospheres from your Shockwave, so 54 versus 56 is no percentage difference. All you do is increase your risk of popping the balloon by going to 6 if you have a calcified spicule. I only do 4, and when I've exhausted my pulses, I just use the balloon like a regular balloon. I'll inflate it to 20. It's just a balloon then. If it pops, that's okay, you take it out. So remember we talked about the concept of cracking the plate and breaking the plate. You crack with the IVL, but you need to break it with something else. And so as long as you're not using an oversized balloon, if you're 1-to-1 to the vessel, you can use that as a balloon at the end to see whether you can expand it or not. So that's number one. Number two, C2 Plus is now available in Europe, 120 pulses. Should be available in the US by the end of the year. And that additional 40 pulses really was designed to allow you to change your lesion prep strategy. And that is right now what people tend to do is they take their IVL balloon into the most calcified segment, they deliver 40 pulses, the lesion is yielded, and then they say, well, there's another lesion 20 millimeters distal, but they can't get the balloon there because it's been expanded. With 120 pulses, the strategy will be go distal, deliver 20 pulses, come back into your proximal lesion, give 40, 50 pulses there, and wherever you're going to put a stent, you should be pulsing. And then the final one is the profile of the foro balloon. That's a fine trade-off. As soon as you reduce the plastic on the balloon pops. And that happened in one generation of this device that you remember that had to be iterated. And so, just like an NC balloon, a foro is harder to get out. Right now, generally that issue can be handled by using a guide extension catheter.
Okay, last question is.
Yeah, may I?
Okay, last question.
Okay.
Same to Ziad Ali. Could you just share a couple of tips and tricks on how to deal with eccentric nodular calcium and an IVL balloon? Because they tend to be very resistant, at least in our experience.
So great question. There are really only biologically two types of calcium that you need to worry about. And that is whether or not the nodule is compressible, right? So by OCT, you'll see two types which are pathological, that's eruptive, non-eruptive. That doesn't matter to you as a clinician. What matters to you whether it's compressible or not. When you see a nodule, start with an NC balloon. If you use an NC balloon and on stent boost or device detection, the nodule disappears, put a stent. If it doesn't disappear, there's two possibilities. And the one that IVL can modify is that you have a marble on top of a rock. You need to break the rock underneath, and that's why the Shockwave helps. So if you crumble the rock underneath, you can push the nodule into it. That nodule, the reason sometimes when you expand it, it disappears is you have a base of lipid. But you can't tell that with intravascular imaging because IVUS gives you a shadow and OCT doesn't have the depth of penetration. So in a nodular lesion, in summary, what you should do is start with an NC balloon. If the nodule disappears completely, stent it. If not, you can actually go ahead and use Shockwave. Shockwave data just got published in JACC Intervention, which shows whether you have a nodule or not. In 250 patients, 50 who have a nodule, you have no difference in the minimal stent area compared nodule versus not nodule. The last question that remains unknown, which I was just speaking to Nick West about, is I think that if you shave and shock a nodule, you probably have a better outcome because the outside of the calcium is the hardest part. So if you cut the top of the calcium off with either a rotoblader or with an orbital atherectomy, then the Shockwave works much better.
Okay, thank you. Owing to time limit, we're gonna finish today's workshop session. We're gonna start the next main session from 8 a.m. in floor 1 main arena. Thank you for your attention.